Hello, I'm Karmakar. Welcome to ISSPS TV. In this next video, I'm going to be presenting to you Popliteal Sciatic Nerve Blockade, the Untold story. If you like any of our videos, do remember to like and share them with your friends. Also, do remember to subscribe so that you can get regular notifications of any future upload. Thank you, Miguel, for the wonderful presentation. As always, you're a champion of microanatomy. Every time I learn from you, today you have introduced a new concept, and I hope to sit back on a Sunday and try and figure out some of what you have just instilled in our thoughts. Thank you again. So, ladies and gentlemen, after these two wonderful presentations by Professor Feigl and Professor Rayner, I will try and make this clinical connection between functional anatomy, microanatomy, and then into our practice of regional anesthesia. Now, while I'm here, let me set up my pointer. Okay, here we go. We have a laser pointer. Now, I have no conflict of interest. For clarity, ladies and gentlemen, I am happy to share some unpublished data from some of our recently completed studies, because without that, I can't really make a lot of sense of what I'm trying to say. Also, if many of you are interested in what I'm going to say today, most of this detail is available in this recent educational publication in regional anesthesia and pain medicine by our group, including Professor Rayner. So you can download this article and read most of it. Now, before I begin, I would like to have a disclaimer in that whatever I say and whatever I show you about the various block techniques, it only applies to the sciatic nerve at the popliteal fossa, number one. Two is, when we think about the sciatic nerve, and as George has alluded to before, it is described as one nerve, but actually there are two nerves that are compactly organized together within a connective tissue layers to form the sciatic nerve. So it's often described that the sciatic nerve bifurcates at the popliteal fossa. That is a wrong concept. If there are two nerves, they can only diverge from each other. So I'm going to use the term divergence, not bifurcation. You know, a branch of a tree can bifurcate into two, but if it were two branches together and they were separating, they can only diverge from each other. So it may seem pedantic, but I think that makes the whole sense of what we are trying to convey through this presentation. So my objective is to briefly review the technique of subparaneural popliteal sciatic nerve block based on the anatomical and microanatomical information that we have, and then discuss with you some of the techniques that are currently described in the literature. Now, while they are techniques that improve clinical outcomes of these blocks, but there are limitations of these, and I'm going to highlight some of the limitations of these subparaneural injections. Lest you go home or you switch off your computer today and you think, I have learned about the holy grail of sciatic nerve block. No, that's not what I'm here for. I want to prove to you that the subparaneural injection is desirable, but we still don't know about popliteal sciatic nerve block, and we are no better than what we were before we started using ultrasound. Now you may say, what are you saying? Actually, today we use ultrasound. We can identify nerves, big, small, medium, whatever, in different areas of the body, and we inject local anesthetic in the perineural area. And in some cases, like the sciatic nerve, we have identifiable compartments into which we can inject to improve the outcomes. But the question is, are they really better than what we used to do before? Okay, I will try and highlight that and discuss some of the potential reasons why there is still a limitation in the sciatic nerve block. Is it just a poor understanding of our anatomy? Anatomy that we have ignored, anatomy that was described more than 100 years ago, that we have never slowly and conveniently forgotten along the way, and developed techniques that we are propagating today, but without proper due care of the anatomy that was already described. And as Professor Feigl also mentioned, that many of the things have been described more than a century ago. I will highlight to you with clinical evidence as to how this is important. And then we talk about how we can improve the anesthetic efficacy. Most of the studies in the literature with subparaneural sciatic nerve blocks are often with as an analgesic technique. They would do the block, do the assessment, and then put the patient to sleep. Now, many clinical practices or surgical practices demand that. But if you are one like me who wants to use it for surgical anesthesia, you will unfortunately be very, very disappointed. And if you haven't used it, or you have used it, you may have found it very disappointing sometimes to find that your subparaneural sciatic nerve blocks are no different than what you used to do with just ultrasound guidance or even with nerve stimulation. Now, these are a lot of philosophical words, but I tell you, ladies and gentlemen, this is my goal today. So sciatic nerve block is very frequently used for anesthesia and analgesia. And as I alluded to, it's very frequently used for analgesia in many practices. And with the use of ultrasound guidance, there has been significant improvement in our understanding of anatomy, particularly with respect to the paraneural sheath or the circumneural sheath, as we discussed with the brachial plexus. The circumneural sheath has been described has been demonstrated to be an integral part of the nerve. As we discussed before, it has often been referred to as the gliding apparatus or even the mesoneurium of the nerve. It's outside the epineurium. So macroscopically and microscopically, it is different from the epineurium. Also, when you inject local anesthetic outside this connective tissue sheath, as opposed to inside this sheath, and if we, for this discussion, use the term extrafascial and subfascial, makes it simpler, okay? I don't have to repeatedly say circumneural sheath, etc. So if you inject a drug extrafascial as opposed to subfascial, they produce different sonographic appearances. More importantly, when you do extrafascial injections, it remains localized in the area that you inject. It does not spread in a longitudinal or circumferential direction over many centimeters along the length of the sciatic nerve, as you see when you inject deep to this circumneural sheath. Also, more importantly, when you inject into the subfascially, it is indeed produces a halo around the nerve, as you can see here. This circumneural sheath can be defined as a separate connective tissue, which is separate from the epineurium or the outer layer of the nerve. And this can produce clinical efficacy differences. As you can see in this demonstration by Dr. Anderson in this cadaver, the subparaneural spread of the dye does not reach the inside of the epineurium. So it is indeed an extraneural injection, given that the epineurium of the nerve is the outer skin of the nerve. As I showed you before, this is a collagenous structure, very elastic. It is transparent, and it tends to hold the local anesthetic or an injectate deep to it. But if you inject enough of the volume, it will eventually burst and dissipate to the surrounding perineural space. With high-definition ultrasound during paraneural sciatic nerve injections, we have demonstrated that the circumneural sheath can be defined as a separate connective tissue layer, which is external to the epineurium of the nerve or the outer skin of the nerve, and is very distinct from the epimysium of the muscles. Now, this is posterior, this is anterior, so this is your biceps femoris muscle, and this is probably the adductor magnus muscle in the thigh. The circumneural sheath indeed circumneurally surrounds the nerve, and it is outside the epineurium. And when you inject local anesthetic, you can see it will contain it. However, when you look at with ultrasound, although you can see the perineural intermuscular tunnel. Now, I'm introducing what Dr. Cornish described as a rigid tunnel. You have a intermuscular tunnel through which the sciatic nerve passes from the pelvis onto the popliteal fossa. The muscle name changes, but the tunnel remains the same. And you can see that even with high definition ultrasound, it's difficult to define this structure before any injection. But I like you to note that the morphology of the sciatic nerve changes significantly. While it is a very flat nerve in the upper parts of the gluteal region and the upper parts of the thigh, it takes on a more rounded appearance and a more bilobular appearance, if that's the right word, as you approach the popliteal area. Again, remember, this is actually two nerves that are indeed opposed together by connective tissue layers. There are also many vessels in the perineural space, including very close to the sciatic nerve. This is often described as the sciatic artery that provides the nutrition to this nerve. As you can see here in the post-injection, subparaneural injection on the sciatic area, you can see the paraneural sheath now pops up. You can see that. It now creates an appearance where the common peroneal nerve is to your left. The tibial nerve is usually larger. So you can see the tibial nerve here. There are circumferential spread of local anesthetic around the tibial nerve and the common peroneal nerve. And as you go up the thigh, it becomes more non-circumferential, but still spread over many centimeters from the popliteal fossa to the upper thigh. So now this creates what most people would have understanding. That means it's like a 1 to 1, and it divides into 2, or it bifurcates into 2. So if for simplicity we say that this is a 1-2 model, okay? So it's a 1-2 model whereby the sciatic nerve divides into 2. You can see here that the sciatic nerve is now 2 components, and the paraneural sheath also separates into 2 and individually surrounds the common peroneal and tibial nerve. Now, this is the common understanding today, and based on which we perform most of the injections. So therefore, the anatomy of the sciatic nerve is indeed more complex than what the literature suggests. What am I saying? Now, the concept of epineurium, perineurium, endoneurium is right when you talk about any nerve. But when you look at the sciatic nerve as it traverses its path from the pelvis on the way down to the popliteal fossa, it actually travels in this intramuscular tunnel, which is the perineural tunnel that many investigators have described. So if we take this entirety, if we go from outside in, you can see that these are the muscles that form the tunnel, and they all have the epimysial layer. So this is the epimysium of the muscle. And then deep to that is the sciatic nerve. Each sciatic nerve, or each nerve within the sciatic nerve has its own epineurium. It has its own perineurium and the endoneurium of the nerve fibers or the axons that Dr. Reina has very eloquently demonstrated in his presentation. The circumneural sheath or the paraneural sheath is now surrounding the 2 nerves or the sciatic nerve, and there is fat in the fatty matrix that's interposed between the 2. So you have 2 compartments. Now you have a subepimysial compartment where you perform the extrafascial injections, and a subparaneural or a subcircumneural compartment, which is the subfascial injections are performed. So you now have 2 compartments into which you would inject your local anesthetic. So obviously, needless to say, the subparaneural compartment or the subcircumneural compartment was described as the sweet spot of the nerve by Dr. Bozat many, many years ago. And indeed, many authors have also described it as the new destination for sciatic nerve block. In fact, there was so much excitement about this that even yours truly often thought maybe this is the holy grail of the sciatic nerve block. Those of you who have performed sciatic nerve block for surgical anesthesia and have been disappointed, like me, would have thought that maybe this is the holy grail which would make us possible to perform sciatic nerve block like general anesthesia. How disappointed we are today. But nevertheless, along the way, Dr. Messer and Dr. Gebhardt from Miami in Florida did this study with three-dimensional ultrasound, although it was manually performed. You can see here they performed a needle on the anterior aspect with the patient lying. I think this is the posterior aspect of the nerve, which is tibial and common peroneal. They placed the needle subfascially and they performed the injection extrafascially. What they showed is that a subfascial injection produces extensive spread along the nerve, whereas a extrafascial injection remains localized. And this is the basis why, because you have a subfascial injection, it contains the volume, and therefore you get much more extensive spread. And this is probably the reason why subparaneural injections produce better outcomes after sciatic nerve block. And what are these better outcomes as demonstrated by these investigators? It produces faster onset of sensory blockade. It produces a higher quality. That means to achieve a given score, if you may. So it produces denser blocks. And more importantly and disappointingly, it produces very long blocks. Sometimes these blocks last up to 32 hours. Now, you would consider a fast onset of the block as a desirable effect of the subparaneural injection. Maybe a denser block in the very outset would be desirable. But a block that lasts for 32 hours in many of my cases, it is not desirable. But because it is a concern to the surgeon, it is concern to you, and to a patient, it is very, very uncomforting. It's very, very unpleasant to have a dead leg for 32 hours, especially if you come for a simple foot operation. But more importantly, these subparaneural injections are less likely to fail. Okay, so now when we do these blocks, and as I mentioned, what I'm going to show you and demonstrate to you only pertains to the sciatic nerve at the popliteal fossa. Most of the published literature describes it as the divergence of the sciatic nerve, where they diverge into two, and there are numerous publications. Above the divergence, there's very limited data, and I will show you some of our work in respect to this with the subparaneural injection below the divergence. And I will try and justify to you why one is desirable and then the other, and so on and so forth, based on some evidence. Now, when you look at the point of divergence, this is the common site where everybody touts is a point of sweet spot for sciatic nerve block, particularly subparaneural sciatic nerve block. Why? Because it is difficult to delineate the paraneural sheath above this site, as I have already demonstrated to you, that it only becomes better visualized where it takes this bilobular appearance, where the sciatic nerve is closer to the popliteal fossa. And at this site, the paraneural sheath encompasses both the tibial and the common peroneal nerve. So at the point where it diverges, the connective tissue sheath is now loosely attached around this nerve. So if you place a needle in the groove between these two, then you are subparaneural, but you're still outside the internal architecture of the common peroneal or the tibial nerve. And when you inject, this tube now contains the local anesthetic and provides you all the goodies that an injection like so does. Like it spreads extensively. It not only spreads up and down the nerve, but also around the nerve. And because you're placing the needle in between the two nerves, it also facilitates atraumatic needle placement. And a single injection spreads quite extensively. Now, as I mentioned, the sciatic nerve morphology changes as you come from the upper subgluteal area to the popliteal fossa. You can see here, even before it starts to diverge, you can see that the two nerves are very difficult to define, and so much so that the paraneural sheath is rarely discoverable in this case or delineatable. You can see here, this is actually the epimysium of the two muscles, that posterior and the anterior muscle. However, as the appearance changes, you will see the sciatic nerve closer to the popliteal fossa in this high-frequency linear scan. You will see they start to diverge, and with it, the connective tissue start to separate, and they also become more clearly definable. You can also see that this is laterally is your left is your common peroneal, and for this discussion, this will be the reference. To your left will be common peroneal, to your right will be the tibial nerve. And if you place a needle in between the two, that's how this technique is described. You can then get spread not only to the two nerves distal to its divergence, but also along the proximal part. Now, this is a cadaveric dissection that I again performed with Professor Sala Blanche in Barcelona. You can see we place the needle. This is just to illustrate to you. This was done with ultrasound guidance in an intact leg in a cadaver. But after we dissected the sciatic nerve out, this is just to illustrate where the needle was placed. And you can see 10 mils of colored dye with methylene blue, not only spread along the top of the nerve cranially, but also caudally to encompass not only the tibial nerve, but also the common peroneal and its branches, maybe the sural branch or its peroneal communicating branch. So you see here, but however, also note that this is not a circumferential spread. It spreads along one side of the nerve as opposed to completely around the nerve. But when you take a closer look intact, it appears to you that it really bots the nerve, not only the common peroneal, but also the tibial, including the main trunk. And therefore, you should, in principle, get a very rapid onset of block, a good onset of complete surgical anesthesia. But is that really true? We will come to that. So when you put a needle at the divergence, you not only see peeling away of the paraneural sheath, you also see separation of the tibial and the common peroneal nerve. There's expansion of the paraneural sheath or the circumneural sheath, but there is no expansion in the nerve per se. And there will be extensive proximal and distal spread, so much so that different halos have been described. So if you look at the main trunk, you'll see a single hypoechoic or anechoic halo around the sciatic nerve, which distally will appear to you as a twin halo because it follows the common peroneal and tibial nerve. So for this discussion, again, when you see 0, that means this is the point of injection. Any -1 means this is proximal cranially to that site, and anything plus is caudal to that site. So if you see here, this is 0. This is about the point of placement of the needle. We place the needle tip here between the common peroneal and the tibial nerve. We inject 2 to 3 cc's of saline. You can see caudally there is a formation of halo around the tibial nerve and some halo around the common peroneal nerve. It has also spread proximally to the main trunk, and it surrounds mostly the posterior aspect because the patient is prone. This is posterior, this is anterior, along the posterior aspect of the sciatic nerve. This is what we describe as a trihalo. Now, you not only see 2 halo, you can see now this is the sural nerve, and this is the common peroneal nerve as they're separating. You can see this creates this trihalo. So the anatomy is now more complex. You can see here, the common peroneal, the circumneural sheath actually follows the individual nerves. And why not? Because this is an integral part of the nerve, and it does so. So much so, if you follow the injectate distally, you will not only see a trihalo, as in this case, you can see the tibial nerve halo, you can see the common peroneal nerve halo. This is the lateral sural cutaneous nerve halo. If you follow in some individuals, you can also see the peroneal communicating branch halo here. This is the lateral sural cutaneous. This is the common peroneal. So you can see a quad halo. So a halo around the nerve distally usually indicates a subparaneural injection. Now, when you perform an injectate of about 25 mils, as in our case of 0.5% ropivacaine or levobupivacaine, this is 0, so this is the point of injection. You can see distension of the circumneural sheath with anechoic local anesthetic, separation of the common peroneal and tibial nerve. It also spreads distally to produce the halo and separation of these 2 nerves. But I like you also see that it spreads quite extensively proximally. More importantly, pay attention to the internal architecture of the nerve. Then you see that there is local anesthetic within the sciatic nerve here, and within the sciatic nerve on what appears to be a kind of a septum between the two. You now can see a halo around the common peroneal nerve. You can see a halo, at least a semi-halo around the tibial nerve with something intervening. And more proximally, this is about the infragluteal area, just below the gluteus maximus muscle. you can see a septum actually appears between the halo of the tibial and the common peroneal nerve. These blocks are usually very rapid in onset, and they produce very quick onset of sensory motor blockade. So what does the subparaneural popliteal sciatic nerve do when you perform it at the point of divergence when compared to a subepimysial injection? It produces faster onset of block. It produces higher quality, that means denser blocks. The blocks are also long duration, sometimes, as I mentioned, up to 32 hours. These blocks are less likely to fail. Now, why do they produce such long durations? Today, there are no pharmacokinetic data with subparaneural injections. But my gut feeling is you are depositing a mass of drug into the subparaneural, subcircumneural compartment, which is relatively avascular. So I believe the washout of these drugs or the elimination of these drugs are slow, and thereby the washout of the local anesthetic from the vicinity of the nerve is slow, and thereby produces very long duration of block. And as I said, sometimes not desirable. So if this were the case and it was all good, then what are the limitations? When you look at an ability of subparaneural injection at the point of divergence and its ability to produce complete sensory motor blockade in 30 minutes, it is rather disappointing. Even these investigators who evaluated them report somewhere between 60 to 92%. But it also depends on the drug you use. If you're using drugs like mepivacaine, you're using drugs like lidocaine, then obviously you get a much higher percentage. Now, not much attention has been paid to the choice of drug for these subparaneural blocks. Hopefully, I will convince you that a shorter acting drug may be more desirable. First of all, we said that the prolonged dense motor block is not desirable. Now, we often think that lidocaine produces short duration of block. You try it using it in a sciatic nerve block, you'll be pleasantly surprised. You get 8 to 12 hours or even longer sometimes of dense motor block after lidocaine, indicating that maybe we should pay some attention to the choice of the drug. So the favored site at the bifurcation is really not ideal. And today there is a paucity of data comparing the different techniques at the divergence, above the divergence, and below the divergence. So with this, we set out to try and evaluate some of this story that really hasn't been told. Another limitation of this hydrodissection at the point of divergence is that occasionally you will find that there's an asymmetrical distribution of the injectate below the divergence. So now if you were to inject it, it will mostly produce probably a very rapid onset of tibial nerve block and a much more slow or a failed common peroneal nerve distribution. So what about above the divergence? We really completed a pilot study, and I like to show you some of the disappointing results. This is the sciatic nerve above the divergence, so you can't really see the common the circumneural sheath. But I believe that, and as shown in histological images, you can see that there are redundant subcircumneural sheath on the lateral side, posteriorly, as well as on the edges of the nerve. So our goal was to try and insert a needle to the lateral aspect of the common peroneal nerve, hydrodissect it, and then place some saline, and then confirm its subparaneural by the various signs that I showed you before, the halos, etc. So we used both nerve stimulation and ultrasound guidance. The needle was introduced in plane for the injection. So you can see here the needle is coming from the lateral end towards the sciatic nerve. This is at the mid-thigh. You can see it's above the divergence, above the popliteal fossa. You can't see the popliteal artery here. You can see this is the epimysium. As you advance and you enter the space, you can see the subepimysial space. You can see that the nerve is now being pushed away. But the moment you breach you slowly advance your needle millimeter by millimeter, you will see that the paraneural sheath will slowly pop out. You can see here the separation of the paraneural sheath, and we try and keep it lateral to it so that you don't inadvertently insert it into the nerve. But I have to say, in this study, we found a very high incidence of paresthesia, about 65% reported by these patients. You can see here the saline has hydrodistended the space and we then inject the local anesthetic at a single site. This is to show you in a video what happens. You can see here the saline. In fact, the needle is touching the lateral aspect of the common peroneal nerve. You can see as you inject, you can see there is a paraneural sheath pops out, and you can see separation and distension of this space. And now you can see the attempted circumneural spread of the drug deep to the paraneural sheath once you start injecting your local anesthetic. So much so that you not only see a good spread around the nerve, but it's not always totally circumferential. You often cover about 60 to 80% of the nerve. This may be related to some of the muscular branches that emerge from either side of the nerve, preventing it. You also get a fascial click when you go through the circumneural sheath. The local anesthetic often spreads about 60 to 80% of it. Great extensive craniocaudal spread of the local anesthetic deep to the paraneural sheath, you can see here. Even with three-dimensional ultrasound, we have demonstrated that the local anesthetic not only spreads in the axial plane, but it also spreads in the longitudinal plane, cranially and caudally. And also in the coronal plane, you can see that there's a lot of local anesthetic spread to the right and left of the nerve. And you can see here, I like you to focus in between the two nerves. You can see a hypoechoic area. This may be related to the nerve that finds its way into the center of the nerve, as I showed you before. This is better seen in this 3D volume that we have rendered. You can see here the tibial nerve and your common peroneal nerve and the paraneural sheath that surrounds it with the local anesthetic deep to it, and some of the local anesthetic that has actually found its way in between the two nerves. On a view from the lateral side, you can see there is a local anesthetic both to the right and left, and in between the nerve, you can see this. In fact, the local anesthetic spreads about 14 centimeters up and down the nerve. You would think this would produce what you really desire for, a real general anesthetic type of sciatic nerve block. The spread cranially is better than caudally, and it covers about 80% of the nerve. If you divide the sciatic nerve into 12 sectors, then 8 sectors with the median distribution. And if you look at the duration, as I mentioned to you, it's a mean of about 17, but the range you can see here in one patient, we had 32 hours. Also, this is a radar plot to show you the distribution of the spread of local anesthetic along the sciatic nerve. So if you imagine this is to the left is your common peroneal nerve, and to the right is the tibial nerve, and this is looking at the halo of local anesthetic around the sciatic nerve just above the divergence. You will see that majority of the local anesthetic is actually spreading between sector 3 and sector 9. And this is where the common peroneal nerve is located. Although it has spread extensively along this route, but it has also spread extensively proximally and distally, so much so that with 25 mils, we've had about 14 centimeters of spread, a very rapid onset of sensory block. You can see sensory score from 0 to 100 on your y-axis, and this is 30 minutes at assessment time. You can see, even if we looked at the individual nerves of the tibial, common peroneals, or the superficial peroneal, deep peroneal, and the sural nerve, you can see the smaller nerves get affected first, followed by the larger tibial nerve. So the tibial nerve is more resistant to local anesthetic. But when we look more critically at the number of patients who had complete sensory is the black area, black bar here. Complete motor is the red area here. You can see that only 20% of this cohort of 15 patients had complete sensory motor blockade at 30 minutes, and only 40% had at 30 minutes. So I think this really was very good for analgesia, and it produced undesirable motor blockade in some for up to 32 hours. But really, for surgical anesthesia, at 30 minutes, it was very disappointing. Now, how does this compare with data that has already been published? This is data published with ultrasound-guided popliteal sciatic in 2012 by German, and the group used 25 mils of 0.75% ropivacaine. In fact, a lot more than what we have used. But look at their incidence of complete sensory block and complete motor block on your left, you see that it's only about 10 to 15% of these patients actually develop complete sensory motor blockade despite circumferential spread was achieved. This is another good work by Didier Moreau and his colleagues, Dr. Choquet and Capdeville from Montpellier. They, in fact, found that at 30 minutes, only about 50% of them had. And when they woke up from the general anesthetic in PACU and they were tested, it was still only about 83% of their cohort of patients, despite a really good dose of ropivacaine that was used. So, ladies and gentlemen, subparaneural popliteal sciatic nerve block at the divergence or above the divergence doesn't seem to be the holy grail of sciatic nerve block that you have been wishing it would be. So it really brings out more questions than answers. So what is the ideal site for injection other than the divergence? Is it necessary to have a circumferential spread above the divergence or below the divergence? The choice of local anesthetic. The more I present you this data, you are now beginning to think maybe we should start to use only lidocaine as a drug, because this would now give you a pharmacokinetic or a pharmacodynamic advantage to produce a bang block. Unfortunately, it produces a high incidence of paresthesia, 65%, but fortunately, when they followed up to about a month, about a week and to a month, they don't have long-term consequences. So this is another study comparing a single versus double injection above the divergence. So this is about 3 to 4 centimeters above the divergence. We again identified the divergence and injected some saline to locate the sciatic nerve and the paraneural sheath, and then perform the injection above the divergence through a separate needle insertion. And in the single group, it was inserted either above or below, and 25 mils of ropivacaine 0.5% was injected. In the group that had 2 injections, they had both anterior and posterior to the sciatic nerve, and the dose was divided into 2. When you look at the single injection group, you can see here, this is the point of injection at 0, and you see distal to it, there's extensive spread along both the common peroneal and tibial nerve. In fact, it covers almost 80 to 90% of the nerve above the bifurcation, and including up to the infragluteal area. This is a 2 injection technique. You can see 1 below and 1 above. We try and achieve circumferential spread as much as possible. Again, the spread was quite extensive up and down the nerve and around the nerve. But when you look at the sensory motor blockade, the double injection certainly won. So you need a even with the subparaneural or circumneural injection, subparaneural injection, a 2 injection is circumferential injection is desirable, and then a non-circumferential with 1 injection in terms of sensory block. The overall motor block at 30 minutes or 40 minutes was also better. But when you look at the sensory onset time, which was our primary outcome variable, the 2 injection group was much faster in onset, and there were no differences in the motor block. But again, when you look at the incidence of complete sensory motor blockade, if you're going to do surgical anesthesia at 30 minutes, even 2 injections with a circumferential spread above the divergence only gives you about 35% on an average complete sensory motor blockade. Now, that's not really a block that you can say is very consistent. It's many repeatable, so that you can use it for surgical anesthesia on a day-to-day basis. If you're prepared to wait for 50 minutes, even with such an extensive spread, you will only achieve about 70 to 80% by about 50 minutes. And I think none of us have a surgeon that is so accommodating or even so patient. Even if you had your procedure room, this would be a very undesirable wait of time. So let's look at below the divergence. So it begged the question whether an injection below would be better than 2 injections above. And in the past, before ultrasound, or even with ultrasound, injecting the tibial nerve and common peroneal nerve separately or on its own was quite common, because this not only allowed you to block the nerves that are much smaller, and therefore you had rapid onset of sensory motor blockade. So therefore, we divided them, randomized them, observer blinded, with levobupivacaine 30 ml, 15 and 15 each, above and below the divergence. Above, I showed you how you do it. Below the divergence, also the same. You hydrodissect the tibial and common peroneal nerve with the two halos. You initially place your needle in the tibial halo. You inject 15 mils. And you can see here there's gradual distension of the tibial compartment. And then you put the needle in the common peroneal halo and you inject another 15 mils. Now you get nice distension of the common peroneal side. This is the spread of injectate after the twin injections below the divergence. You can see here this is 0. So this is above and this is below. You can see below there is extensive spread with a very well-defined septum-like structure in the middle. And as you go more proximally, you can see now the local anesthetic is trying to hydrodissect its way between the two nerves, separating the nerve into a tibial component and a common peroneal component. And again, even more proximally towards the infragluteal area, you can see separation of the two nerves. When you see such separation, there are two questions that came to my mind. Is it an intraneural injection? Certainly not, because we've done a subparaneural injection. Again, why is this two nerves separating out? This is the next question. I will come to that in a short while. So you can see here that the two injections below were outcome-wise much better. 93% produced readiness for surgery, and almost even at 50 minutes, you have now about 80% of them having complete sensory motor blockade. Again, you see here that despite your choice here, that even with the ropivacaine or levobupivacaine, we only get about 35 to 40%. This is no different than what you did without subparaneural injection. Now, finally, before I end, I like to show you that this separation of these two nerves into a common peroneal and tibial nerve with spread of drug within the paraneural sheath was something that we were taken aback in the early days when we performed this injection, but it was quite consistent. And you can see there's a septum-like structure that comes up, it gets organized in the middle, and this forms kind of a septum between the two nerves with the two halos that separate the main trunk of the sciatic nerve now, both at and below. As we said, if you review the literature, somebody has already found it before you. The time that often people say there is nobody or no one has done this before, it sometimes means that you haven't looked hard enough. Didier Moret and their group from Montpellier already had demonstrated that if you had separation of the tibial and common peroneal nerve during an ultrasound-guided sciatic nerve block, you often found that they had reported that sensory motor block was complete within 15 minutes, and the separation of the sciatic nerve into two components was often associated with a very rapid chirurgical block. Now, this is a picture they presented many, many years ago. You can see here, now you can see that there's a tibial nerve and the common peroneal nerve, and you can see some hint of a septum here. So what is this? A structure that you see in the middle between these two nerves. Because I'm running out of time, I'm already over, so I just want to quickly mention that it's almost 100 years, more than 100 years from today, that Compton had described the intrinsic anatomy of the large nerves in the Journal of Anatomy. These are his drawings from that very article. You can see here, you can see this is proximal, this is at the mid-thigh. You can see between the tibial and the common peroneal components, you can see he drew a septum between the two nerves, as where the two nerves come together. And in fact, this is a diagram I drew based on the descriptions of that article. And you can see here, this septum is not going directly anterior-posteriorly. It's an oblique septum that goes through the nerve, sciatic nerve, between the two components. And this is described as the Koku septum. So sometime when you say somebody's gone Koku, that means no. It's the Compton-Cuvelier septum, based on Compton and his colleague Cuvelier, I suppose. And you can see in this scanning electron microscope, this area is filled with this fibrofatty connective tissue, which Dr. Reyna already mentioned to you. And they come together between the two nerves. Often in histological section, it is more difficult to see in the hematoxylin stained. And when we compared our ultrasound images with some of these histological sections that Dr. Reyna had in his laboratory, where he had injected the red blood cell marker with a hematocrit of about 10, and the injections were performed at the divergence. When you looked at the section above the divergence, you can see that this pink area represents where the red blood cells had spread. And now you can see that it's not truly a circumferential spread. You can see a lot of local anesthetic actually gets into the nerve on either side of what appears to be a composite formation of a septum by these collagen fibers, the blood vessels, and the other structures that are within the architecture of this nerve. And this is just about 11 centimeters above the divergence. You can see between the common peroneal and tibial nerve, there's a lot of this injectate of the marker between the two nerves. And this probably accounts for the septum that we can see in the ultrasound. So in conclusion, I have illustrated to you the subparaneural popliteal sciatic nerve block and how it improves block dynamics. And there are several techniques that have been described, including the twin injections below the divergence. Certainly is not the holy grail of the sciatic nerve block. The two injection below the divergence as a subparaneural injection appears promising. It nevertheless produces very prolonged duration of block with the long-acting local anesthetics. I think a choice of a shorter acting drug may be desirable, and this is an area that we are investigating currently. It produces a high incidence of paresthesia, but fortunately it does not lead to long-term consequences, as our short-term follow-ups have shown. We have drawn attention to the Koku septum, the Compton-Cavalier septum, which was described more than 100 years ago. So now we've come a whole circle after 100 years, and now this is the structure that may play a part in the distribution and spread of the drug within the sciatic nerve. And thereby, if we are to produce surgical anesthesia, we have to pay attention to this septum. Future dedicated research in this area is being planned. Thank you, ladies and gentlemen. With these few words, in fact, many words, I would like to end my talk.